Okay, very good to have you all back in this room. Many of us, not for one good reason, for two good reasons. This session is the McKee's session, and we're very honored to have two distinguished speakers. Tom Novacheck and Wade Shrader. They're both prominent orthopedic surgeons who have contributed to a big change in the field, making us realize not only the importance of orthopedic surgery, but how we should really integrate a vision, a multidisciplinary vision, including considerations that relate not only to surgery, but also to outcomes. Tom Novacheck chairs our sister academy, the American Academy of Cerebral Palsy and Developmental Medicine. And Wade is also on the board of director of that distinguished academy. We sometimes sit together there, and it's really nice to sit together here. I have these certificates, which I will hand depending on how good they have been. So the first speaker will be Tom. He comes all the way from Gillette. We've learned a lot with Gillette, and many of us have integrated the ideas of Gillette in our practice, so it's very good to have him. And it's very good to have a session that is so strong on orthopedic surgery. We used to say that the EACPDM had more focus on orthopedic surgery, which is not true. They have more focus on children and adults with developmental disabilities in really a multidisciplinary way. We used to say that the EACD didn't have so much interest for orthopedic surgery. Yes, do you remember those days? Far gone. Thank you.
Well, Wade, I was asked to talk about hypotonic cerebral palsy. How about you?
I thought I was the one doing on artificial intelligence. I don't know, right? So I don't think we were quite prepared to do the dual presentation. I didn't bring my bow tie, nor did I have a hat, actually. Sorry. But anyway, we'll move on and do our more traditional talks. We just.
This is it. That's all for the jokes.
It's right there.
Oh, there it is. So, yeah, can I have the first talk? That's for you, Bernard. It is a true honor to be here today in person, and it's a true honor to be able to do this lecture, and I appreciate the opportunity to be able to be here in person. The presentations here at this meeting have been really high quality. I'm humbled to be giving a plenary session lecture in the midst of the very high quality talks that we've had. So we'll jump right in. What do we know about orthopedic surgical procedures for ambulatory kids with cerebral palsy? We know that we can improve gait and function and x-ray findings, but it's less clear about any positive impacts on the global aspects, particularly in the long term. When we offer surgery, what's the reason? Is it for current issues? Well, sometimes it is. There's a problem on the x-ray, or there's a problem with pain, or there's some worsening function. But oftentimes, the conversations that we're having are about future concerns or a desire for better function. And how do we counsel patients and their families in those situations? Do we understand the natural history well enough to do so? And what if we don't do something instead of doing something? So to try to get to these issues, I'm going to look at 4 studies that we've been able to do in the long term in early adulthood across multiple domains of the ICF and compare these interventions to retrospectively matched control groups for an internal SDR study, a multi-center SDR study, a study of crouch gait and the treatment with or without DFEO PTA, and the treatment of femoral anteversion and abnormal internal hip rotation gait with femoral derotational osteotomy. And I have to acknowledge that there are many people who contribute to this effort, and without all of their efforts and time and financial support, I wouldn't be able to present this information today. The first study is our internal study looking at the long-term results of SDR. The goals here were to look long-term at these multiple aspects of function across the multiple domains of the ICF. And our hypothesis here was that the SDR was going to lead to better outcomes and fewer subsequent treatments compared to a control group. To be included, a person had to have an SDR, diplegic cerebral palsy, gait analysis, minimum follow-up at 8 years, and minimum age of 16. We then used the random forest algorithm to do retrospective matching across these multiple important aspects of cerebral palsy. And it turned out that this model had a very high degree of accuracy. At follow-up, we did multiple surveys for satisfaction, quality of life, pain, participation, function, and mobility. We found that at long-term follow-up, the SDR group had substantially less subsequent treatment for soft tissue surgery, bony surgery, and subsequent intramuscular spasticity injections. We found that spasticity was significantly different at long-term across multiple muscle groups, with a score of 1 on this scale being complete resolution of spasticity. We know that gait improves with interventions, and both groups improved similarly. There were greater improvements in the knee and the ankle in the sagittal plane for the SDR group. The surveys, however, showed no difference. Both groups are actually doing well. There was low pain interference, high quality of life scores, and similar functional assessment questionnaire results. Energy showed an advantage for the SDR group. So what we thought this provided to the literature was that it was a unique study design with a retrospective control group, that there were similar good outcomes, better GDI for both, although it was actually better for the control group than the SDR group. There was better spasticity control and correction with the SDR, and that the SDR group subsequently received less treatment. The second study was then the multi-center study, again looking at SDR, and here we paired with 2 Shriners hospitals that we felt had similarly high quality gait analysis, orthopedic surgery, and research programs, but a significant difference in that at Gillette we have a comprehensive spasticity treatment program, but at the Shriners hospitals there's less focus on spasticity control. We designed this study very similar to our internal study, so that our pre-registered hypotheses were very similar. We use the same retrospective baseline matching algorithm and similar outcomes measures, followed them for at least 10 years and at least 20 years of age. I won't be going through all of the results here, but focusing on the quality of life scores and anything that was different from our internal study. So for these graphs, the red is the SDR group, the blue is the no SDR group, and here for participation, you can see that there's no significant difference for involvement or control scores. For the 4 domains of the WHO-QoL brief, you can see that there's no difference between the 2 groups for physical, psychological, social, or environmental. In regards to satisfaction with life, there was a tendency for the no SDR group to have higher scores in the very satisfied category, and for the quality of life measure, very good ratings were higher and more frequent for the non-SDR group. And finally, for the Diener, there was no significant difference on the Diener scale for quality of life. But if you take all 7 of these measures and combine, there was a small magnitude but consistent trend towards higher quality of life scores in the no SDR group. So for our pre-registered hypotheses, we did find that in fact there was lower spasticity. Again, I didn't show you all of this data here in the interest of time. And there was actually lower pain and stiffness. There was a small magnitude trend favoring the SDR group, and significantly larger gait improvement. But we didn't find less orthosurgery, better function, higher quality of life, and low energy. The third study is now turning to orthopedics. So this is distal femoral extension osteotomy and patellar tendon advancement for the treatment of crouch gait. This study was published in the Journal of Bone and Joint Surgery in 2018. Our purposes and hypotheses were similar to the previous studies. We wanted to look at multiple aspects of the ICF, and we hypothesized that the DFEO and PTA group would be doing better than those who had crouch gait and didn't have those interventions. And we also hypothesized that they would have better gait. Our design was that we matched for the presence of crouch gait and knee flexion contracture initially. They had their gait analysis and ended up undergoing some treatments. The DFEO PTA group, of course, had that treatment. The other group may have had some other treatments. We followed them over time, and they had their standard of care treatments over time. We followed them then at long term at 20 years minimum age and at least 8 years after entry into the study. For the DFEO group, we had 28, and the non-DFEO group, 23. If we look specifically at what we're treating, crouch gait, on kinematics, we see that the DFEO PTA group in the red is worse at baseline. Their crouch gait is worse. At long term, there's improvements for both groups, but greater improvements for the DFEO PTA group. If you ask yourself if they're still in crouch, the answer at initial contact is that there's a high incidence of increased knee flexion angle at initial contact, but a significant difference in mid-stance. And if you look at both of those criteria together, you're roughly twice as likely to still be in crouch if you don't have the DFEO PTA than if you do. So if we look at the gait-specific measures, there is a decreased risk of crouch. There's improved extension of the knee and mid-stance and improved gait quality in the DFEO PTA group. When we looked at the other issues of activity and participation and quality of life and satisfaction with life measures across multiple domains, there were no differences identifiable based on these two categories. So in answer to our questions, there were changes in structure and function that favored the DFEO PTA group, but not across the other domains of the ICF. And finally, the fourth study is a study about femoral anteversion and abnormal internal hip rotation gait treated with or without a femur derotational osteotomy. And this was published just last year in Gait and Posture. The FDO participants had bilateral CP, underwent FDO, had no pelvic osteotomy. We looked at their gait quality, and we only included individuals that we felt had acceptable gait quality, and that other standard of care interventions were allowed for both groups, and both groups were a minimum 25 years of age at follow-up. The non-FDO group, again, was matched based on anteversion and mean stance hip rotation. And at baseline, the groups were matched on most of the outcome variables, except that the non-FDO group tended to be stronger in the hip abductors. At long-term follow-up, we did physical exam, a modified hip abduction test, gait analysis, EOS, and questionnaires. The questionnaires were similar to the other long-term follow-up studies, but we added trip and fall questionnaires and also multiple questionnaires looking at global pain and joint-specific pain. This is GMFCS 1 and 2 that I'm going to be able to tell you about here today, 13 to 25 years after entry into the study. We had a hard time identifying people who didn't have an FDO. Most of the time when the recommendation was made for FDO, people underwent it, and 9 of the 11 who didn't have an FDO had it recommended initially and didn't undergo it. The other treatments were different. There were more treatments in the FDO group, so keep that in mind. At long term, for these multiple specific measures, there were no differences in hip rotation, hip abduction moment, foot progression, GDI, walking speed, step length, and hip abductor strength. In terms of gait and anteversion, there was a large difference measured on EOS, that there was a 29-degree better measurement of anteversion for the FDO group. Hip rotation and foot progression angles showed large improvements for both groups, and we did not have problems with recurrence in the FDO group. Step length and walking speed tended to decrease slowly over time. Our long-term functional outcomes were equivalent for nearly all of the queries. There were small positive effects for the FDO group with less hip pain and greater hip abductor strength. The hip abduction test was similar for the two groups. Trips and falls were frequent. You can see that there was a slightly greater frequency for the FDO group, but this was not correlated with hip rotation or foot progression and is consistent with other authors. The vast majority of patients in both groups did report pain. This agrees with previous studies and is higher than typical developing peers. But interestingly, back and foot pain were more intense, frequent, and chronic than hip pain. In terms of quality of life, again, the four domains of the WHO-QoL brief, no difference between the two groups, the non-FDO on the left and the FDO on the right. For participation, the scores were higher for the FDO group. The modified Harris hip score was similar for the two groups. And the satisfaction with life was also similar, but you can see with a large spread. The findings of this study made us wonder if an FDO is necessary to maintain or improve joint-specific parameters such as hip rotation, moment, and abductor function, because all of those improved whether you had it or not. So the appropriateness of an FDO may depend on how quickly the patient desires the improvements, including gait appearance, and/or may be indicated radiographically. Both groups showed reasonable maintenance of their functional improvements at the long term, and these outcomes can supplement our counseling sessions about how FDO may help an individual reach their shorter long-term goals. So if we summarize all four studies, in early adulthood, the target of these interventions and some of their effects on gait remain corrected and are better than controls. But there's little evidence of clear impacts on quality of life. Both the surgical and retrospectively matched control groups were actually doing pretty surprisingly well. They were doing better than we expected, actually. Our impressions of gait, makes us wonder if our impressions about gait deterioration, aka natural history, if they're overestimated or biased. And why was surgery, you might wonder, why was surgery offered and chosen by some and not on others? After all, this was retrospectively matched on all the data elements, but it really makes you wonder if that big data approach really gives you all of the answers. And what if we follow these patients longer? These are early adulthood. What if we followed them into mid-adulthood? Would they be functioning differently at that point? But we should be careful to not oversell the effects of our interventions during clinical encounters. So our take-homes for clinical care are to remember that CP, of course, is permanent and irreversible. The presence of one or two of these particular impairments are just a small part of the whole equation. There are many other factors to keep in mind. And in fact, the relative contribution of any particular surgery to an individual's wellness may be relatively small, and that the socioeconomic and health behaviors play a bigger role than what we may. And there's a common saying in orthopedics that there's nothing like long-term follow-up to ruin a perfectly good outcome. Thank you so much.
Thank you, Tom. Without transition, we're moving to Wade, who's the second vice president of the AACPDM. Wade.
Thanks, Bernard. Well, it's just a great privilege to be here at EACD and to be asked to give one of the plenary talks, as Tom mentioned. It's a great honor and privilege to represent the American Academy here, and I'm just very honored to be here with you today. So I've been tasked to talk about outcomes of orthopedic surgery on quality of life in non-ambulatory children with CP. There's my disclosures. So our treatment goals, I think all of us, when we treat non-ambulatory kids, as we do with ambulatory kids, but we want them to be pain-free. We want them to be happy and satisfied with their life and reach their potentials. Especially when we start talking and thinking about non-ambulatory kids, we want to make their caretaking easier. And as Tom mentioned, prevent problems from arising into adulthood. And we want a high quality of life. So what is the quality of life and how do we measure it? And what tools do we use, in particularly when we're talking about non-ambulatory kids and kids that have intellectual disabilities and communication disabilities? That becomes quite challenging, right? So how accurate are these tools? And historically, how well has the orthopedic surgery measured this in the literature? And probably, I'd have to say, not very well, unfortunately. So we mentioned the World Health Organization, their definition of quality of life is, as you all know, individuals' perception of their position in life in the context of the culture and value system in which he or she lives, and in relation to his or her goals, expectations, norms, and concerns, and I would add, in their families. And as Tom mentioned, the 4 domains there that is measured in some of in the HUBREF quality of life tool. So I think there's been a major shift in focus here in the last 20 years that probably have made a big shift in our orthopedic literature. First is the ICF, of course. The second is GMFCS. And the second is the focus on patient-reported outcomes and the focus on quality of life. So ICF, as you all know, the orthopedics typical focus has been on structure. And Tom did a good job of talking about a shift to activity and participation, but I would argue that that's relatively new in the orthopedic world. If you look back at our literature, even 20 years ago in our own journal, most of our orthopedic papers were entirely radiographic outcomes. So I think the ICF has certainly had a big impact on all of us. I think it has the potential to make even a bigger impact on our orthopedic outcomes, as Tom mentioned, in those outcomes for ambulatory kids. Of course, GMFCS is incredibly important, and we know it's valid and reliable and relatively stable. But I think, again, when we're thinking about things in non-ambulatory children, it's very important for us to help with communication, sure, but it also is prognostic, which helps us predict natural history, so that we're not doing surgeries just to treat x-rays and to treat contractures, but we're actually helping the families come together with us to help proper goal setting for us to determine the appropriate treatment for each individual child. And then finally, the shift of focus to patient-reported outcomes really allows us to better measure the quality of life. And of course, PALSY was one of the first ones, which was an effort of Posna and the Shriners, which was very effective, but has issues, as I'm sure you know, and toward some floor issues in terms of measuring quality of life on children who are non-ambulatory. CPQOL, of course, is another very highly touted tool and is very useful, and I like that a lot. But I think CP Child, really, when we talk about in the non-ambulatory children, has really kind of changed the world. And we know this was from Uni Narayanan and his group at Sick Kids. It's validated, it measures quality of life, but it also measures comfort, pain, and positioning and caregiving, and really focuses on caregiver priorities. And as we know, it's focused on GMFCS 4s and 5s, and has really become the standard in how we measure quality of life in non-ambulatory children. So we're going to talk a little bit about quality of life and look at what the orthopedic surgery literature says on hip dysplasia, on scoliosis, on upper extremity, and briefly on foot deformities. So, and I'd say this in the context, of course, with our new paradigm of our traffic stop system. And of course, when you look at the orthopedic surgery, we don't score very high on this system, right? And so I hope that this shift in focus that I mentioned will certainly impact our future studies so that hopefully we can bring orthopedics up into the green and join all our colleagues here at EACD, right? So, first of all, hip dysplasia. We know that hip dysplasia is a progressive issue. Most of our children are born with normal hips, and a combination of motor delays and asymmetric muscle forces cause their hips to subluxate and then ultimately dislocate. We know that it's a linear function of GMFCS, so our 4s and 5s are at highest risk for that. So what is the effect of hip dysplasia on quality of life, and is it painful? Well, quite frankly, again, the historical literature was quite unclear, but it did show that up to 50% of patients in chronic care facilities with hip dislocations complained of pain. We now know from some modern literature that hip pain is a prominent feature of chronic pain and cerebral palsy, and it has been suggested to be correlated with migration percentage as well. So let's look at that again. So Jung et al. Was the first group to measure the CP Child and its relationship to migration percentage. And they showed a significantly linear decrease of CP Child total scores with every 1% increase in migration percentage. So the more that the hip was out of the socket, the lower the CP Child scores. And those findings were independent of GMFCS. It's totally a function of migration percentage. Terry and his colleagues reported on their experience in Norway, and they looked at GMFCS 3 through 5 patients. and they found that with migration percentages greater than 40%, they had lower scores in the CP child domains of comfort, emotions, and health. And this is a common thing that we'll bring up again in terms of the overall domains of CP child. Boston Children's has done a prospective cohort study on GMFCS 4s and 5s. And again, they showed a very similar value to the previous studies that showed the preoperative migration percentage was negatively correlated with the pre-op CP child score. So I think we can say that how we measure quality of life in GMFCS 4s and 5s, that hip dysplasia does seem to negatively affect that quality of life. So does surgery help prevent pain? Well, Freeman Miller's original article on hip reconstruction was probably one of the first patient-reported outcomes in our orthopedic literature in CP back in the 90s, that he felt it was important to ask the caregivers, was the surgery beneficial? And 89% of them said it was. No standardized tool, just asking a simple questionnaire. Freeman's follow-up study confirmed that and showed that 97% of the parents said that they'd do the hip surgery again, although we know that it's a big deal during the initial recovery. Again, going back to the Boston Children's study, that prospective study, they showed that post-operatively after hip reconstruction, they showed an average increase in the CP child scores over 5 years. And that, again, the CP child score improvement is directly related to the improvement in migration percentage. So it's directly related to our surgical outcomes. And again, the domains that were improved in that study were positioning, transfer and mobility, comfort, emotions, and overall health. It's important to note, as Terry reported from the Norway experience, that the caregiver burden did not change, and that's expected, right? We didn't really change the overall disability level, but hopefully we made these patients more comfortable and had better quality of life by those tools. The epidemiology of scoliosis and cerebral palsy is similar, but slightly different than hip dysplasia. If you look at severe scoliosis that with a Cobb angle of more than 40 degrees, our friends from Australia showed that it is also proportional to GMFCS 4s and 5s. And we feel that there's some benefits in spinal fusion, that they have increased seating and positioning that might lead to improved participation. We haven't really proven that yet. We feel that subjectively that it has some improved pulmonary and GI issues, and also decreased amounts of pain, decreased risk of pressure injury, and of course decreased risk of deformity progression. But of course in scoliosis, you have to balance that against a significant risk of complications, with overall complication rates up to 20 to 50% and infection rates up to 15%. So again, the spine fusion improved quality of life. So go back to Freeman and the DuPont legacy. Again, he asked the similar questions to our patients undergoing spine fusions, and 65% of them felt that the families felt they sat better, and 86% of their caretakers recommended surgery. And when we updated that in 2008, it was found that up to 96% of the caretakers reported satisfaction with the survey. Boats et al. Was the first to use CP child in this population for spine fusion with 50 patients, and again found improvements in the CP child domains of comfort, emotions, health, and overall quality of life, and again had a 92% satisfaction rate, and 100% would do it again. The HARM study group, which of course is an international multi-center group that we're a part of, is probably the largest study on looking at scoliosis and CP and looking at CP child. And again, they found the best improvement, again, in comfort and emotions and positioning, transfers, and mobility. Overall, the overall scores were modestly improved, which again shows that it does not change the overall disability. This was really important, I thought, from this last study, was that the caregiver rated it as one of the best medical interventions, second only to the G-tube that their patient had undergone. So, and again, the HARM study group did a risk-benefit analysis, weighing those risks that I mentioned before, and in that risk-benefit analysis, they concluded that yes, it was worth it when you measure quality of life. So moving on to the upper extremity, wrist and hand contractures are very common in patients who have GMFCS 4 and 5 function, and can cause significant issues with hygiene and dressing. Well, what does the literature say about quality of life for that? It's not as much, and no one has used CP Child to date for that, but Van Hees showed improvements in their disability assessment scale and showed improvements in hygiene and ease of care after wrist fusion, and the Shrine study demonstrated improved hygiene and improved cosmesis. And then finally, what about foot deformity? Is there any evidence of the impact of foot deformity on quality of life? We have to definitely say we're in the yellow range for this, is that our evidence, there's really nothing in the literature that looks at this. My personal experience, though, are that families are often thrilled to be able to have their child wear shoes again. Just that simple, normal aspect of life. And for kids with really severe deformities, it can allow for improved AFO wear and standing and possibly improve their participation. So how can we do better to improve the quality of life in patients who are undergoing orthopedic surgery? I think we need to continue to refine and have better measurements and tools and continue to focus on the families and patient goals, and we'll talk about that in just a minute. And I think it's vital that we have an understanding of the family psychosocial environment needs and perspectives. So better measurements and tools, I do think CP Child has changed the way that we've measured quality of life in these kids. And it's important, the domains of CP Child are important to our families when you ask them. But I think we continue to need to refine the ways we measure success. And the modification to explicitly ask our families, what's important to you? There's a continued focus on families' goals in terms of, in the ambulatory kids, the group from Edinburgh, as well as Tim Theologis's group, is doing great things and asking specifically about what families' goals are for their surgical outcomes. And I think we need similar focus research on 4s and 5s. Then finally, I think the understanding of that family psychosocial environment needs and perspectives totally impacts everything. And this gets to the biopsychosocial model of health. And we know throughout other areas of orthopedic surgery, carpal tunnel release, rotator cuff repair, total joint arthroplasty, the preoperative psychosocial state in terms of anxiety, depression, and grief totally affects our quality of life and outcome scores. So if it does that in those disease conditions, we know that it has to affect our families who have these really complex psychosocial situations. So we need to focus on that. And I think finally, many families struggle to fully understand that scope of the trajectory of having a child with a lifelong disability, especially for our kids who are non-ambulatory. So we need to provide those services if needed, and I think we need to help them and use these tools that I've mentioned to help provide realistic expectations to communicate with the family with preoperative education and to help the surgeon and family goals become aligned. Thank you.
Thank you very much, both Tom and Wade. We've seen people wave the flag of function in many of our sessions. And it's a beautiful flag. But today we've heard about pain and we've heard about life. And I think this is really central. We've heard also humility on the part of surgeons with extensive clinical experience, how they measure their experience, they gauge it against methodologies, very sound methodologies, with profound questions with regard to relationship between ICF dimensions. So do we understand those relations well enough? Do we use the right tools to measure what we do? You both raised the question. And we have a question here from Con Daly, who's watching us. And that's a question for Tom, but I suppose it can be for the duet, really. And it says, on an individual level, having done those studies, having read those studies, how does it change your everyday practice in terms of decision making? If, when, and so forth.
Well, thank you very much. The room is large. I can't tell if Iona is here, but she made a comment. There she is. You made a comment this morning that I want to refute. You said cattle are smart. I grew up on a dairy farm. I can tell you that cattle are not smart. Why do you think I'm an orthopedic surgeon and not a farmer? I got tired of chasing them through the fence instead of going through the open gate. Yeah. So in terms of individual conversations, I do think that we are changing the way that we do the counseling. I'll give you a specific example. So it was very common for us before these studies to say that tone is going to cause stiffness and pain and that you're going to need more orthopedic surgery. And these studies pretty clearly show that that's not the case. What SDR outcomes do show is that, and I didn't really dwell on this, I mentioned it briefly, is that the stiffness scores are worse. And we wonder particularly about the next 10 to 15 years of ongoing spasticity or the absence of it, and whether those things will lead to bigger differences in pain, because we haven't seen differences in pain currently. So the other part of it is that I think that, and Wade actually touched on this as well, that what we really want to do and do a better job of is tying our conversation specifically to the goals that the patient expresses or the family expresses, and at least do a better job of documenting that. And we are working on that with implementing the goal score into the work that we do. The final comment I'll make two. One is that the FDO, we're doing our radiographic outcome study. That'll get more directly at it, and our early look at those data suggests that there is a real difference between FDO and not, so I think that needs to continue to be factored in. And for an intervention like the DFEO PTA, which is so powerful and so corrective, and with real long-term differences, and again, the crouch issues may become accumulative over time, and we want to test those patients in 10 to 15 years.
Thank you, Tom. I have a question for Wade. It was inspired to me by Tom, because Tom said that CP is permanent. He emphasized by saying that it is irreversible. But we also have the clinical notion that, at least from the orthopedic point of view, it is progressive. You mentioned interventions, and then you think about lifelong perspectives of patients. How do you inscribe it in time of real life?
Yeah, that's a great question, and it goes, I think, to trying to identify those, for each individual patient, what the trajectory is going to look like, right? And that can be quite difficult. And I think that gets into, it crosses the boundaries, of course, between ambulatory care and non-ambulatory care. I think in some ways, in the non-ambulatory world, it's a little bit easier for us, I think, in terms of, we're talking about progressive scoliosis and progressive hip subluxation that we've watched. I think we have enough evidence to say and very clearly help the family try to understand what life would be like if we did not do that intervention for those disorders. I think for the ambulatory kids, it gets a little bit more muddied, and certainly Tom's work with those outstanding long-term outcomes have certainly caused us to pause a little bit more before we reflexively recommend surgery for a gait impairment that we see. And then, as Tom mentioned, really work hard with the families to help them articulate those goals, and then us try to meet in the middle to see if there are appropriate treatment strategies that we can do to try to help them reach those goals in the future.
I guess from reading on your faces that there are many questions, so don't hesitate to raise your hand. But in the meantime, while the microphone is getting there, you both insisted on the ICF model, and you recognize that your target is body structure and function, while having in mind activity and participation. How do you organize, because I know that you work in a very multidisciplinary way, how do you organize an intervention that would target conjointly what you do in surgery with body structure and function and activity and participation?
Well, I think that's key to successful outcomes, Bernard, right? And I think if we don't do that, then we get into where we're just treating the x-rays or just treating the contracture, as I mentioned. I think that multidisciplinary team that you mentioned is absolutely key. We have to all communicate together, and that multidisciplinary team needs to include things like rehab and our therapists, and all have to be involved in the preoperative discussions, not in the postoperative discussions. So we all have to do that together, including rehab psychology. I think that's a very important part of that.
The one comment I would make is that, sometimes as we're seeing kids and we're following them, we're doing serial assessments and maybe including gait analysis. And maybe we're not seeing any deterioration, and maybe at that point it's reasonable to continue to hold until we start to see some deterioration in function, at which point we can have a timely intervention that will not only address the body structure and function issues, but also the participation and quality of life issues.
And of course, having in mind, and you reminded us, that quality of life is not part of the ICF, and it's a fundamental, if not primary, dimension. So there is a question from there. Yep.
Yeah, hi. Sound okay? Yeah, they were good. Hi, Tom Wade. Nathan Rosenberg, Nationwide Children's Hospital, Rehab Medicine, Columbus, Ohio, United States. Just have a question. The humility that I saw in this talk was just stunning. To say we need to take a step back and we need to look at the individual patient. And having heard you guys on stages a lot in the past, I think those of us in the crowd, those of us that are here, we hear that and we do that. Although there are so many other providers that we work with, there are trainees, there are people that we are bringing up through fellowships. I'm wondering what ideas you guys have about how we work with our trainees to instill in them the humility that I see in both of you.
Well, Nathan, thank you for that question. And I think both you and I work in an environment where it's multidisciplinary. And I think that the real key to being able to instill those ideas and that perspective is to be in a multidisciplinary clinic. And I've had the incredible opportunity, learned so much. In my hardest mental days are the days that I spend in spasticity clinic alongside the neurosurgeon and the physical medicine rehabilitation doctor, because they make me think outside the box.
And it's Tom's quote that said, nothing ruins long-term follow-up outcomes than more long-term follow-up, right? And I think as surgeons in particularly, we have to very critically look at our outcomes because we are doing a very specific intervention that has technical aspects of it. Of course, there's judgment aspects of it too. And I think there has to be an environment and a culture of your organization and your team to critically look at those outcomes and be able to say in the gate lab or when we're doing our post-op reviews, maybe we didn't make the right decision for that child. And why didn't we make the right decision? And kind of deconstruct it and really have that as a pervasive aspect of the culture so that the trainees see that and they think that's the norm.
And so an important point that you also underlined, and it comes out of this discussion, is we should go on refine our tools, our instruments, to measure in the most relevant way what we want to measure. Because when we see those studies, we might believe, without really analyzing, that there's a disconnect, a full disconnect between ICF dimensions. But no, there are relationships, and we need to highlight those better with help from people with lived experience. This is history of our field in the making, as you see, and things are moving, and they're moving in a very promising direction. Today, EACD, and then the next appointment that we have with these gentlemen and with our community is the AACPDM annual meeting for the first time in years, physically in Las Vegas, and that it's in September. So on behalf of the EACD, on behalf of McKees Press, I think that we are very honored to present you with those certificates.